Okay, and our next speaker is Dr. Megan Waldrop, MD, pediatric neurologist at Nationwide Children's Hospital, and assistant professor of pediatrics and neurology at The Ohio State University College of Medicine. Thank you so much.
All right, good afternoon, everyone. Thanks for inviting me so I can share what we've learned from our trial. These are my disclosures. And so this is a gene replacement study for IGHMBP2-related conditions. This is a protein that's fairly ubiquitous. It is an RNA DNA helicase and it interacts with RNAs, but it's not exactly known what the function is, but we do know that it leads to nerve degeneration. The disease is caused by biallelic loss of function mutations, and it's actually a spectrum of disease that is caused. So in its most severe form, it's called spinal muscular atrophy with respiratory distress. And in the more milder form, it's called CMT2S. There is quite a spectrum, and it's not very dichotomous. I'd say there's quite a range from the work that I've done now that I've learned over what the phenotype can look like. So in general, for the more severe form, this presents very early in life, and it's usually kind of co-happening kind of bulbar and core weakness. And additionally, there is a length-dependent process that's happening. I just don't think a lot of people notice it because perhaps child neurologists are not really examining young children until after they present. But from my experience in seeing many of these children now, there does seem to be a distal component that kind of can precede and can happen concurrently with the dramatic kind of respiratory distress onset that happens. And it's usually some sort of respiratory illness or a sedation event that kind of triggers this dramatic fulminant onset. And there are muscles that do seem to be relatively spared in these children. So they do seem to maintain shoulder internal rotation. They maintain elbow extension. They maintain knee extension, kind of hip extension, back extension for much, much longer than many of the other muscles. And then without intervention, these children will pass away pretty early in life. They need a trach and they need a G-tube to be able to survive. On the milder end, these are children who don't have any sort of precipitous respiratory event from what I can tell early in life. They, at some point, will present with what seems to be a length-dependent weakness. Typically, foot drop is noticed. Probably around the time when they're starting to walk is when these kiddos will typically present. And it does seem to be ascending, slow kind of progress. What's interesting about these individuals is that it seems like at any point they can develop respiratory distress due to phrenic nerve involvement. So it's very stressful for the parents of these children because they're always wondering when's the other shoe going to drop, when is this awful thing going to happen? They don't quite know. So preclinical work was done a bit of time before I came into the picture by Dr. Meyer, and she had co-collaborators both at the Jackson Lab and at Ohio State University. And from the other talks in this presentation, an astute question was, should we do IV or should we do intrathecal? And based on this study here and this data, Dr. Meyer's group really felt like intrathecal was the way to go. There's lots of other, evidence out there that led to this decision, which we can talk about at the end. She did a remarkable preclinical program. She looked at 3 different mouse models with 3 different severity types. This is the most extensive IND package we had ever submitted to the FDA within terms of just the sheer amount of preclinical data that we had. I don't have the time to walk you guys through all of this, obviously. And what's interesting is all of these mice were dosed at postnatal day 1. Typically, we like to see them dosed later in life to really get a better idea of true efficacy. But that decision was made because of the shift in the AAV tropism in mice. The study team was blinded to all of these efficacy outcomes, though. This is just one representative slide of the outcome in the mice, and showing that the mice that received either the SSAAV9 with one of 2 different promoters both did very well in terms of survival. So we also had extensive safety studies done, and these were again done blinded. And we also did it in non-human primates. There was no efficacy studies done in the non-human primates, just safety. And For the most part, the results were pretty unremarkable, right? The FDA wouldn't have let us move forward if they were not. There were really pretty benign findings in terms of laboratories. The only thing that was concerning to me, looking at it as a clinician, thinking I'm going to be the first one putting this in a human ever, was that a couple of the mice had reduced heart size. One of the non-human primates had some mild inflammation seen in the heart. So that made me change my protocol and add on cardiac monitoring to the clinical study. And then there had been reports of the dorsal root ganglion toxicity that we've seen in other platforms. So this all led to the initiation of the clinical trial, which began in 2021. And because this is an ultra rare disease, we were interested in keeping it very open. So we had very broad inclusion criteria. You needed 2 pathogenic variants. We had a broad age range, and then we just said they needed to do the outcome measures. Exclusion criteria where we didn't want anyone with abnormal liver function. Obviously, they couldn't have antibodies to AAV9. They needed to be able to receive an intrathecal injection, so they couldn't have any contraindications to that. There's some issues with potential toxicity if they had the JC antibody, so we tested everyone for that. And then, of course, at my discretion, any sort of illness, anything that would preclude them from the study, they would not be included. The goal was 6 to 10 participants. We had a dose of 9, 10, 8, 13. We did it in the IR suite. We had them in the Trendelenburg position, head down 15 degrees, infused over 5 minutes. And then we did have prednisone initiation before. And we did have one crib negative participant who also had the addition of sirolimus. And our primary outcome was safety and tolerability. So to date, 7 participants have been dosed in the trial. We've also dosed 3 additional participants outside of the trial. They're not reported here, but I will say their findings and outcomes are not really anything different than what we've seen in the trial. So the FDA required that we start with older participants first and then slowly work our way down. And so that's why we started with the CMT2S phenotype. The first participant was an 11-year-old, non-ambulatory. I'm just showing the ALT GGT just because everybody's interested in liver response, but really I was not super worried about liver response in any of these individuals. None had any serious AEs related to the product, and the only AE that is of interest and that we're continuing to investigate is some of the participants had elevation in the CSF protein. Mostly at 6 months, there was one where the peak was at 3 months. So we are continuing to monitor that. We've added some additional studies to the CSF. We're now doing MRI imaging as well. I don't know if there's anything else I want to comment on here. I will say participant 2 was a screen failure, and then participant 7 unfortunately passed away in the course of the trial, but we felt like that was due to disease progression. The child had rather abrupt onset of respiratory distress right prior to dosing. We had a clear, frank discussion with family and decided to proceed with dosing, knowing that it may have been too late. So to date, we do feel like it's been largely safe. So there's been no adverse event that has led to escalation of care. And by that, I mean additional immunosuppressive agents or anything like that. There was one participant, possibly 2, had a little bit longer prednisone course, but nothing out of the norm. And then again, nothing that we feel has been directly related to product. We do have AEs that are, in my opinion, due to disease progression, which brings into the question of, is this efficacious? And then we did have that one participant death who had significant disease progression prior to dosing. So I'm putting on GGT here, right, because everyone's interested in liver response to AAV products. And we did have the 2 participants that had the most or the highest elevations in the GGTs were those with the diagnosis of SMARD. And what I know now from conducting my natural history study is that in general, approximately half or so of the infants with SMARD tend to have elevations in AST, ALT, and sometimes even GGT. That seems to happen when the disease becomes more severe. And so for participant 5, he had some elevation post-dosing, but then you guys can notice later on between months 12 and 24, he had an additional very significant elevation that we do not feel is related to the AAV product. We think that is, again, related to his underlying SMARD diagnosis. And this is just a graphical representation of the CSF protein elevations that we have seen. So it does, in graphical form, look like around the 6-month time point, everybody does seem to have a little bit of a bump. And so that, again, is something that we're looking at in more detail. No patient or participant has had any symptoms that have coincided with this. And so we haven't changed our management. We haven't added prednisone or anything. The first participant that this happened in, we did bring in for a follow-up LP within a month after the 6-month time point, and the levels had dropped. And so we felt that that was reassuring. So now looking at outcomes, it was hard to design a study when you didn't have full set of natural history data in a very rare disease population. So we kind of had a broad smattering of outcome measures that we used, one of which was the neuromuscular GROW. So the reason for that was while we were trying to do our natural history study, which only started about a year prior to the product being available, also started right during COVID, so we had to adjust. The neuromuscular GROW was something that was developed at Nationwide Children's Hospital, could be given over video. And so that was something that had been done in some participants in our natural history study. And so we wanted to continue that into the trial to see if we could gather some information. And so you can see that hashed line down the middle. Everything to the left of that represents those who were in the natural history study, and everything to the right of that represents them post-dosing in the trial. And really what you can see is maybe some stability, but there does seem to be some decline in some of the participants over time. Looking at the 9-hole peg test in the box and blocks, so this was not done in those with the SMART phenotype. This was done in the individuals with CMT2S. And you can see for participant 1, he ended up going through puberty in the course of the trial, had a large growth spurt. And then, is that the true cause of this or not? That's when he had a significant decline in those 2 outcome measures. And the revised upper limb module scores, again, seem to decline over time. What's interesting and perhaps a glimmer of hope in this trial is that for 2 of our CMT2S participants, respiratory function has remained stable. So the first participant, he did have a growth spurt, but he also has had, I'd say, some difficulties following clinical care recommendations, and so has had some just decline in overall health status, is choosing not to get a G-tube when we were recommending a G-tube for weight loss, choosing to not be aggressive with respiratory care. So I don't know how much of that is, disease progression versus, not receiving recommended standard of care. But I am holding out hope for those 2 participants where the respiratory function has remained stable to perhaps slightly better over the course of the study. So in summary, the outcome has not been as anticipated. I didn't have the time today to show you guys the extensive preclinical work that was done, but it seemed very promising in a mouse, right? But humans are not mice. And also what we talked about after the first talk is, transit time down the nerve. How long does it take to get there? And again, that the distal kind of delivery of AAV is not great. So this is a condition, at least for the SMART participants, that once it happens and it goes quick. And so my concern is that dosing intrathecally, perhaps we didn't have the luxury of time for it to travel down the nerve to have dramatic impact. So we are revising a bit, and we still have some product available. We're reserving that now for pre-symptomatic or very early symptomatic individuals to see if that might be a way for us to see signs of efficacy. We are considering our dosing route. Some people have suggested dose increase. That makes me a little bit nervous, not knowing what's going on with the CSF protein at 6 months, but this is kind of where we're at with the study, trying to be thoughtful and make sure that we're doing the best with what we have for the remaining participants that we choose to dose. I think these are my acknowledgements. Of course, it takes a huge team to both do all of the preclinical work and the clinical work. And then I have a data safety monitoring board that is helping us kind of as we move forward, thinking about who to continue dosing, when to kind of revise and go back and consider additional dosing routes. So I think that is all that I have for you guys. Thank you.
Hi, one question Online? Hello. Nice talk. I have a question online. It says, what was the trend observed for Rome and any explanation?
So it was I feel like a decline. Can I go backwards or no? So over time, it did seem like they declined over time. If I can get back to, and I think that looks pretty clear here that
But is there any explanation?
I mean, I'm just considering it's disease progression. So we didn't have any kind of abrupt, no family reached out to me and made me have a concern that they were having some kind of adverse event. It just seemed like they reported, yeah, things have been progressing over time. Or to be honest, most of the parents have reported they think that they're fairly stable. And then when we do our assessments, that's when we note the decline.
Okay.
Hi, Megan. Rob Burgess from Jackson Labs. Very nice. In the mice, eventually there's actual motor neuron loss in the ventral horn of the spinal cord. So is this more analogous to spinal muscular atrophy and, is kind of a long-term stabilization and not I mean, gene therapy is not going to bring back a dead motor neuron. So, is kind of the long-term stabilization maybe the best that you should be hoping for, at least for the SMART patients?
Yeah, I definitely think so. I think I had great hope in the beginning that if we caught them right when that plummet started, I could halt the plummet. But I think you have to kind of wait for that plummet and then holding them there, I think is the goal for the SMART participants. But that's, of course, why I would love to dose them as early as possible. But again, it's hard because it's not something that's very common. Not many people think of it because it's so rare. So they typically aren't diagnosed until they have that respiratory event. I will say that for one of our participants, not dosed in the trial, he did pass away. There is an autopsy underway, so we might be able to learn some more information once that's been analyzed.
So you mentioned that the autopsy case is on the way, and it will be very important to learn, right, so about distribution from that case. But have you looked at the maybe expression or levels of this transgene protein in the CSF?
So we have CSF reserved. There's not a great antibody, and so at this point, I think measuring remains difficult. I consider the CSF that I have very precious. And so when I feel confident that we can do something reliably on that data, then we will. But at this point, I don't feel like I can risk that. We will be doing neurofilament levels. There's some other stuff that's planned. We're batch grouping, so that all gets sent out within a couple of months because we've just had our last. We'll have participant 6 through 3 years in the study. Yes.
Can you hear me? Yeah.
Yes.
Great work. I'm wondering, we just saw a great talk about SARM1 inhibitors preventing neurodegeneration, and almost anyone I talk to agrees combination therapies are a really great idea.
Yeah.
And it seems like no one's doing it, and it's probably because of reasons that are bigger than all of us. But do you have any thoughts on that? Like, how do we start doing things that really make sense that have a better chance?
I mean, when I was listening to that talk, I was very interested and I had ideas. So I'm just a clinician. I do not have a lab, but I'm happy to start conversations. I definitely think we need to be revising the standard quo at this moment, or at least the treatment of CMT and perhaps some of our other neurological conditions. Yes.
Chris Larson, University of Missouri. Very nice talk. It seemed like you were a little bit negative on potentially the vector, but I'd also like, not really a question, more of a comment, that the patients who received Zolgensma after they had developed symptoms, acted much like your patients did. And it was really only newborn screening that really changed the way that Zolgensma acted. And so I would hesitate to throw, this out and say, I hope for stabilization. I think it might just be a context and when you deliver it, not what you delivered.
Yes, I definitely think it's when. I think for SMART, at least, it needs to be much, much earlier. There have been some SMA individuals who've been treated when symptomatic and have actually gained some function. And so I don't think they're responding exactly the same, but I hear what you're saying, and I am perhaps a little too negative, but it's not what I was hoping for, right? So I had all the experience with SMA. I had an experience with another clinical trial that I did in DMD. And then I had this, and we had such hope. And I think there's more work we need to do to make it better, unless, we can get IGHMBP2 conditions on the newborn screen, which I don't think is going to happen. So we've definitely got to revise this product, I think, to have a better outcome.
I actually have one final question before we cut you off, which is, did you test for anti-drug antibodies in patients?
We have not.
Thank you.
Okay.